So we're going to discuss the following topics in this lecture: venous thoracic outlet syndrome, lower extremity DVT thrombolysis, superior vena cava syndrome, and inferior vena cava filters. Let's begin with thoracic outlet syndrome. We're going to focus on venous thoracic outlet syndrome. That's also known as Paget-Schroeder syndrome, effort thrombosis, and that presents in patients with pain and swelling of the affected upper extremity. There are other types of thoracic outlet syndrome, as we all know. Arterial is one of them, and that's highlighted by a cervical rib. And what happens is that cervical rib can traumatize the subclavian artery, cause aneurysm formation there, clot forms in that artery that can embolize down to the hand. So these patients present with severe upper extremity ischemia and pain. Neurogenic is the most common type of thoracic outlet syndrome, accounting for 95% of it. Also associated with the cervical rib, which may traumatize or compress the brachial plexus, and these patients present with pain. But we're going to focus on the venous thoracic outlet syndrome, and this is basically caused by compression of the subclavian vein within the thoracic outlet, or inlet, if you will. And that's compressed by three major structures: the anterior scalene muscle and its tendon, the first rib, and the clavicle anteriorly. And there's a subclavian vein running in that little cavity right there. So you can imagine if there were hypertrophy of this muscle, if there were callus from a rib fracture or clavicle fracture, or a lot of fat packing that area, that would compress that vein, and that's what happens. So some of the risk factors that lead up to this would be manual labor. Athletes are at risk for this, especially weightlifters, tennis players, pitchers, a muscular build, a lot of truncal obesity, again, trauma, as we mentioned. Iatrogenic causes would include central venous catheter placement in that region. The flow through dialysis, fistulas, and grafts can cause problems in that area as well. So the treatment for venous thoracic outlet syndrome is aggressive thrombolysis if indicated. Surgically decompress the thoracic outlet by excising the first rib, maybe part of that anterior scalene muscle. If necessary, intraoperative angioplasty after the decompression, really not before, and subclavian vein stenting as a last resort. I'll explain some of the rationale for that in a moment. So we can diagnose thoracic outlet syndrome with something called the Adson's maneuver, which is a venographic maneuver. And essentially, here's an example of that maneuver being done. Here's the patient with subclavian vein narrowing. You can see some collaterals going around it already. And this is with the arm in neutral position or adducted. When you abduct the arm, raise it above your head and turn your head away from the affected side, we see marked compression of the subclavian vein and even more collaterals forming here. So this would be a positive Adson's maneuver indicative of venous thoracic outlet syndrome. This is a clinical case just to solidify some of these facts. So this is a 42-year-old plumber who presented with right arm swelling. Duplex exam demonstrated absence of flow in the subclavian vein. He was referred for a venogram, and we could see in the brachial and basilic systems extensive thrombosis throughout, and it all goes up to where the subclavian vein terminates. You could see that's terminating right where the first rib crosses the clavicle. So this would be compatible with effort thrombosis, Paget-Schroeder thoracic outlet syndrome. Evan mentioned the use of multi-cycle infusion catheters with thrombolysis, and that's what we would use in this case. There are also some mechanical thrombectomy devices we might consider as well, but we used infusion of thrombolytic in this case. The agent we used was tissue plasminogen activator. A typical rate for this application and other applications, say lower extremity thrombolysis, would be 1 milligram per hour, up to 1 milligram per hour, directly through the catheter. And you can see these little markers, little beads on the central and peripheral aspect of the thrombolytic catheter, and those are all side hosts between those two markers, so we're actually bathing the clot directly with the TPA. So after a day and a half infusion in ICU with ICU monitoring, we have this appearance. The veins are open in the upper extremity, but we can still see a narrowing here where the first rib crosses the clavicle. So that would be compatible with the narrowing of the subclavian vein at that level. We could see the nominate vein and SVC are patent central to that. So one might be tempted to do something further here to angioplasty this lesion or to place a stent there even, but it's recommended that that's not done because basically you still have those rigid structures in the thoracic outlet right there. Nothing's been done about those rigid structures that caused the problem in the first place. So if you try to angioplasty that, you might damage the wall of the vein by compressing against those bones or that muscle. If you try to stent that, the stent itself may not open completely and it may be deformed by those rigid structures. So the key here is to do surgical decompression and then an intraoperative venogram the vascular surgeon will do. And if there's still a narrowing there, either the vascular surgeon or one of the interventional radiologists will go and do an intraoperative angioplasty. So treatment complications of venous thoracic outlet syndrome would include bleeding at the puncture site. You're using TPA, and as Evan mentioned, we have the same contraindications for using thrombolytic agents, the same risk factors, so there's a chance of remote bleeding as well when you use TPA. Arterial injury, this would be one of the surgical complications. Pneumothorax, phrenic nerve injury, infection, all of these are really complications of the decompressive surgery of the thoracic outlet region, and rethrombosis and treatment failures as well. Next, we'll discuss lower extremity DVT thrombolysis, and there's a whole laundry list of risk factors for DVT, as we all know, and I think probably everyone in this room has at least one of these risk factors. I know I do. If you traveled on a plane to get here, that was a risk factor. Risk factors that have gotten a lot of press lately are hormone replacement therapy, contraceptive agents, hypercoagulable states. Those are important risk factors. Another really important one is May-Thurner syndrome, and we see a lot of this in our practice. And this is defined as compression of the left common iliac vein by the right common iliac artery. And we can see that on this venogram here. Here's the IVC. Here's the left common iliac vein compressed by, you can see mass effect by the right common iliac artery here, that impression. And you see collaterals going across the pelvis and these paraspinous, paralumbar collaterals diverting flow around this compressed region. More common in females versus males, although we have seen it in male patients, and associated with a thin body habitus, although they're not universally thin, the people who get this. So the indications for iliofemoral DVT thrombolysis would be lower extremity DVT, especially in a younger patient. We want to prevent damage to the valves in the veins, prevent them from getting the post-phlebitic or post-thrombotic syndrome later on in life if it's treated by traditional anticoagulation. Phlegmasia ceruleodolens, this is where the degree of venous obstruction is so severe that it impairs arterial inflow into the extremity. And this is an emergent indication for this. We'll come in the middle of the night to treat patients with this to avoid loss of the extremity. Severe pain or morbidity from the DVT. Preservation of the femoral venous access site. This would be important in a dialysis patient, or if a patient is on tap for a renal transplant, for example, and you want to keep that iliac vein open, we would do it in this case. And again, prevention of the post-phlebitic syndrome, which I mentioned earlier, which is caused by damage to the veins from the clot and long-term morbidity from venous reflux and recurrent DVT. So the technique for thrombolysis involves popliteal vein access with ultrasound and catheter-directed TPA infusion, as described previously. We often employ mechanical thrombectomy now that we have better devices for doing that. And if there is a lesion, such as a May-Thurner lesion, we can actually stent that with good long-term patency. The reason why we access the popliteal vein is because you're going in the direction of flow. And we can clearly see the popliteal vein. This is a patient who's prone on the procedure table. So the popliteal vein is superficial to the popliteal artery. You can see thrombus in the vein. And all those thrombos, we can still access that with ultrasound guidance. We have a catheter in the popliteal vein. And we have flow going through the superficial femoral vein. We could see thrombus throughout, all these filling defects throughout the superficial femoral vein. And this is actually a trauma patient who had pelvic trauma. We could see evidence of that with these healed pelvic fractures, and we can see flow in the common femoral vein all the way up to this point where it terminates, and this is probably a result of the trauma that they had before. So this patient underwent DVT thrombolysis as described and brought back about a day later, and again we see the point where the common femoral vein terminates. We're able to traverse that with a guide wire and catheter and do a venogram. We could see pretty much complete obstruction of the iliac venous system, and that responded well to just placement of a stent. And again, the patency for venous stents in the setting is pretty good, so he did fine after this. Treatment complications similar to what we've seen before with thoracic outlet bleeding at the puncture site or remote, since you're using a thrombolytic agent, arterial injury, vein rupture. If you're stenting a really stenosed vein in the pelvis, you got to be careful you don't rupture that. You can place a covered stent if that happens. Rethrombosis and treatment failure. Superior vena cava syndrome is the next topic we'll discuss, and that's defined as partial or complete obstruction of the superior vena cava. Most common etiology is bronchogenic carcinoma. Other malignancies can cause this, lymphoma, sarcomas, of course. Inflammatory processes such as histoplasmosis, coccidioidomycosis can cause fibrosing mediastinitis, depending on what part of the country you're in, and that could be a cause of this. We often see this with chronic central venous catheters and in patients with a lot of torrential flow going through there who have dialysis fistulas or grafts that can lead to SVC obstruction as well. The symptoms in these patients can be quite severe. If you've ever seen one of these patients, facial edema and flushing, they can have headache from the increased pressure in the head, dyspnea, cough, upper extremity edema, since all that straining through the SVC to the heart. They can have pain, dysphagia as a result of this. So here's a clinical case or clinical example of a patient with SVC syndrome, and this is due presumably to this indwelling chest port catheter. We can actually see the chest port reservoir here, catheter going into the subclavian vein coming across, and we see termination of flow from a bilateral venogram right where the innominate veins coalesce where the SVC should be formed. Instead of flow through the SVC, that's occluded, and we're seeing collateral flow going through internal mammary veins, the azygos system, and ultimately these collateral pathways will connect with the IVC in some way, and then that's how this flow will go back to the heart. Not an ideal situation. This patient was very symptomatic as a result of this. So the treatment of these would be treat the underlying cause if possible. If it's due to malignancy, if it's due to an indwelling catheter, see if you can treat that. If it's malignancy, that's going to take time to resolve, so you may have to do other things as well. Medication, anticoagulants to avoid thrombosis, diuretics to relieve some of the congestion, and percutaneous recanalization can be very effective. We can do angioplasty of the superior vena cava, angioplasty plus stent placement. It's usually a more chronic stenosis that we're dealing with, not really acute, so thrombolysis might be indicated, but usually not needed. So here's that same case that we saw previously with the SVC syndrome secondary to the chest port catheter. We were able to, from a arm vein access, advance a balloon right across the SVC, got a guide wire and catheter and balloon across that, and we dilated that up to 14 millimeters in diameter. And you want to remove the inciting agent that caused the SVC syndrome, but apparently this patient may have still needed the chest port, so that was left in place. And we just actually advanced the balloon alongside the chest port catheter and successfully opened up the SVC. Complications are similar to the other interventions we described previously: rupture of the SVC, which could be serious if you're in the part of the SVC that's within the pericardium. So you want to be very careful not to overdilate the SVC, because you can rupture that and cause cardiac tamponade if it's within the pericardium. Bleeding, stent migration or deformation. Again, this could be another serious complication. If you're stenting the SVC, you want to be sure you size your stent appropriately. Probably better to oversize than to undersize it so it doesn't migrate into the heart. And in lots of cases, we just can't cross the obstruction, and so there would be a treatment failure. We'll finish up with a discussion on inferior vena cava filters. And we'll start with some stats on DVT and PE, venous thromboembolism. DVT affects 2 million people in this country annually. Overall incidence of PE is greater than 600,000 cases per year. Fatal PE, greater than 200,000 cases per year just in this country. Standard therapy, as we all know, is anticoagulation. However, a large percentage of patients develop recurrent venous thromboembolism despite anticoagulation. So the indications for filter placement would be patients with a contraindication to anticoagulation, patients with a DVT or a PE with contraindication to anticoagulation, a complication such as a bleeding complication while on heparin or Coumadin or one of the other anticoagulants, recurrent DVT or PE despite being therapeutic and anticoagulation, that would be an indication for a filter. In some cases, if there's free-floating thrombus in the IVC, even though you can anticoagulate the patient and prevent this from increasing in size, there's still a risk that this might break off and embolize to the lung if it's free-floating like this, so we might place a filter above that to prevent that from happening. If the patient already has severe comorbidity, severe cardiopulmonary disease, and they probably couldn't tolerate even a small PE, we'll place a filter in that setting kind of prophylactically in that case. And if the patient's poorly compliant with anticoagulation, that might be an indication for a filter as well. There are some relative indications for filters. Prophylactic filter placement in trauma patients. Before we saw the removable filters, we weren't doing very much of that here. We were doing a lot of this. I worked in the Midwest for a while, and we were doing a lot of it there, but not so much on the West Coast. But now that we have retrievable filters, which we'll discuss a little bit later in the lecture, we are doing this now, especially at SF General, our Level 1 Trauma Center. Almost all the trauma patients there receive a filter at some point in their care. High-risk patients, who are patients who are going to be immobilized for a long duration, like an orthopedic surgery patient, for example, preoperatively prior to immobilization after an operation, patients with hypercoagulable states, with or without venous thromboembolism, such as malignancy, one of the other hypercoagulable states that we saw before. So to treat all these patients, different types of filters have been developed, and these are basically the 5 kind of prototypical filters, and we'll discuss each one of these. The stainless steel Greenfield filter, it's one of the early metallic filters, the Greenfield filter, bird's nest filter, Gunter tulip, the Optes, and the Option. And these last 3 filters are retrievable filters. So key points about the stainless steel Greenfield filter is that it's stainless steel, so it's ferromagnetic, and there might be some MRI safety issues with this. We'll discuss that in a moment. This will accommodate an IVC up to 28 millimeters in diameter. This is deployed over a wire, which attempts to keep it from tilting, but it still does tilt, and even though it does tilt, it's still effective at trapping clot or preventing PE. Bird's nest filter is interesting in that it's this composed of these 2 hooks that fixate in the wall of the cava, and you deploy this mesh of wire here, this tangle of wire that basically traps the clot, prevents it from embolizing to the lung. This is also stainless steel, ferromagnetic, so there's an MR safety issue with this one. It can accommodate IVCs up to 40 millimeters in diameter, so in some patients with larger diameter IVCs, you may consider using a bird's nest filter. This, like the Greenfield filter, is a permanent filter. Once it goes in, it's not coming out unless someone operates and physically removes it. Gunter tulip filter. This was one of the first approved removable filters in the United States, and this follows that same kind of umbrella conical configuration of the Greenfield filter that most filters have. This one has a hook at the apex, which allows it to be removed from a jugular approach, and we'll describe that in a moment. This is retrievable, and this will accommodate an IVC up to 30 millimeters in diameter. The Optes filter, this is one of the nitinol filters that are on the market. A lot of filters are now made of nitinol. Nitinol is a very malleable, flexible material, and when it's chilled, it can be compressed down into a small delivery sheath, which makes it ideal for filters, stents, and what have you. This filter has this kind of biconical shape to it, and so it really doesn't tilt because of that. However, and it is removable. However, the hook is on the inferior aspect of the filter, so if you're going to retrieve this or remove it, you have to do it from a femoral approach. You can't do it from a jugular approach. Although you can insert it from either femoral or jugular approaches, you have to remove it from a femoral approach. And this will accommodate a cava up to 3 centimeters in diameter. This slide shows some of the newer generation filters that are on the market now, and we're using a lot of these in our practice. Most of them, they're all retrievable. They're all nitinol. Most of them have that conical shape that was first introduced by the Greenfield filter, the Select, the Denali, the Option filter. The one that's unique here is the Crux filter, and this has a double helical configuration, a double helix, and the filtration takes place in this lower helix here, where you have this Dacron netting that actually traps or breaks up clot if it embolizes or attempts to embolize up the IVC toward the lung. What's also unique about this filter is that it has hooks in superiorly and inferiorly, so you can actually retrieve this from either a jugular or femoral approach. So these are the newer generation filters. Some of you are probably familiar with at least one or a couple of these. Before a filter is placed, we always do an inferior vena cavogram, and in that cavogram, we're looking for thrombus in the iliac vein, in the IVC. We can do this from the jugular. We often place this from a jugular vein, so advance the catheter down into in the lower part of the IVC, and be sure that we eliminate any evidence of clot in the IVC. This will show us caval anomalies. We'll discuss those in a moment. You want to see or determine the level of the renal veins, because we usually place these in an infrarenal location, although sometimes we'll go suprarenal with these. And you'll want to measure the caval diameter, which the maximal diameter for most filters, as we discussed, is 28 to 30 millimeters. As I mentioned, most filters are placed infrarenally, but in some cases you'll place a filter suprarenally. In the setting of renal vein thrombosis, if you want to prevent that renal vein thrombosis, renal vein embolus from embolizing to the lung, you have to place a filter above it. IVC thrombus, it extends above the renal veins. You'll place a filter suprarenally in that case. If you have an infrarenal filter in place and thrombus, and that is thrombosed and thrombus extends above that, you can either lyse that thrombus or place a filter above it suprarenally. In a pregnant patient, to prevent the gravid uterus from compressing the filter, you may want to place it a little bit higher, and that may result in a suprarenal placement. Here's an example of a patient who had extensive caval thrombus. This instrument is at the level of the renal veins. This is thrombus all the way up to the renal veins pretty much, and we placed a suprarenal filter to protect the patient against PE in this case. Another really interesting case of a patient who had a filter in place and developed symptoms, underwent an ultrasound looking for a recurrent DVT, and what they found actually was thrombus involving the filter and extending above the filter. So in this case, the options would be to place a suprarenal filter. You could also consider lysing this thrombus, doing thrombolysis of the cava to remove this. It was elected to actually place a suprarenal filter instead. So here's the original filter, which we see has thrombos there, and above that we've placed an Optese shape. This is actually a trapeze, non-retrievable filter, but it's shaped just like the Optese, if you can make that out. So that's a suprarenal filter placement. One of the reasons, as I mentioned, that we do an inferior vena cavogram is to assess for caval anomalies. And this also reminds me that to tell you that whenever you're considering placing a filter, you all already know this, but if they have any cross-sectional imaging in the abdomen, it's worth looking at that, because you can actually be fooled, and you can do a vena cavogram from the right femoral vein access and see one IVC going up, not even knowing there's a second IVC on the left side. And if you have a CT and look back at that, then you'll say, okay, he has two IVCs, have to deal with that. So it's important, if they have it, to look at the cross-sectional imaging beforehand. But the anomalies that we're looking for are duplicated IVC, left-sided IVC. All of these would affect filter placement. The lack of an IVC, patient may be symptomatic because they don't have an IVC, not so much from a DVT. Circumaortic left renal vein, that affects filter placement as well. So here's an example of a patient with a duplicated IVC, and we actually have catheters coming in from a bilateral femoral vein accesses and doing a inferior vena cavogram. The fact that we already have two catheters in this venogram tells me that whoever did this probably saw the duplicated cava on a CT or something, and they said, okay, so let's just confirm this, and that'll also give us access to place filters in both caval moieties, if you will. The reason why we do this is because if you just place a filter in one IVC segment, you won't protect from DVT going up the other side. So you can place filters in both moieties, or in this case, you can place a filter above where the two cavas coalesce at the level of the renal veins. And that's what was done here, probably because these IVCs are fairly narrow, and they probably wanted to avoid potentially obstructing these or thrombosing these off with a filter in such a narrow channel, so they placed the single Optese filter above in a suprarenal location. Circumaortic left renal vein. Normally we would place a filter infrarenally just below the main renal veins here. If you do that in this case, it's theoretically possible for clot to travel around the filter through the circumaortic left renal vein channel up to the lung. So in this case, you want to place either filter lower down below this left retroaortic component or higher up in a suprarenal location, and we elected to place it below the circumaortic renal vein. I mentioned and described some temporary filters earlier, and the indications for that would be short-term protection against during thrombolysis for iliofemoral DVT or cable thrombus, before surgery in patients with DVT who don't want to anticoagulate because of the surgery. If the patient's at risk for bleeding during pregnancy, you may place a filter, removable filter then, so you don't have to anticoagulate them. And in patients with a short-term contraindication to anticoagulation and a risk or known venous thromboembolism, you'll place a temporary filter in those cases as well. What's ideal about these filters is that they can be removed when they're no longer needed. This is an example of a Gunter tulip filter being removed from a jugular vein approach. As you recall, the hook on the Gunter tulip is apically, it's superior, so we come from above to snare that. And before we do that, we'll want to do a venocablegram again to check for any clot in the filter itself. If there's a lot of thrombus there, we're going to leave the filter in and consider something else, another plan. But here's the filter in place, there's no thrombus. You really can't make it out that well here, but you can see here that we've come down, we've actually snared the hook of the filter, and what we do in this case is advance this larger sheath. We don't really pull the filter into the sheath, we advance the sheath over the filter to collapse the leg, pull them out of the wall of the cava, and then remove the filter through the sheath, or just remove the filter and sheath as one unit. This is that Optes filter we saw earlier where the hook is on the inferior aspect of the filter. Cablegram demonstrates no significant thrombus here. We've engaged that lower hook with our snare device, and here we are in the series of images just advancing the sheath over the filter as opposed to pulling the filter into the sheath, and then this whole thing is removed as a unit from the patient. Now this would be an irretrievable filter. This is a filter that's basically done its job. Some clot embolized and the filter trapped it before it made it to the lung. So we can't take this filter out, of course. So the options are to leave the filter in, just declare it a permanent filter. You can try to thrombolyse this clot with TPA or use one of the mechanical devices to lyse the clot there and then take out the filter. Or you can simply anticoagulate the patient and bring them back in 3 weeks or a month. And that's what we tend to do when we see this. And the body's own inherent thrombolytic mechanisms will often have dissolved this clot when they come back. And it might be worth, having them come back and doing a low-dose CT with contrast before you actually puncture them to do another venogram, balance that, the radiation versus the risk of the puncture. But they often come back a month later, the clot's resolved, and then you can remove the filter. There are numerous potential complications of filter placement. The major ones deal with thrombosis and filter movement or migration. And let's talk about thrombosis for a moment. When you look at the risk of cable thrombosis, it's all over the map from 2 to 30%. And that seems odd. Why would there be such a range? Well, part of the reason for that is that often these filters, well, first of all, they may thrombose the cava because you have a foreign body in the cava, but often the thrombus occurs because the filter has done its job by trapping the clot before it went up to the lung. So you can't fault the filter for that. It's just doing its job. But in a lot of patients, the thrombus is there, but it's asymptomatic. And it's found incidentally on, say, a repeat image, a CT scan or something. And then they see thrombus, and they're like, oh, okay, or they have an ultrasound, and it shows thrombus in the filter, but the patient's completely asymptomatic. So that's why there's such a range here, because some of these studies include patients who are just symptomatic from the thrombus. Others include all-comers patients who are symptomatic, and those where it was found incidentally and they aren't symptomatic. So that's why there's such a range here. A note about MR safety. Most of the currently used filters, like the ones I showed in those newer generation filters, they're safe to scan right after you put them in. They're known as MR conditional. And they're safe to scan under certain manufacturer-specified conditions, such as you can't scan a patient in greater than a 3T magnet. That's not a problem for most of our practices. There are spatial gradient criteria, 1600 to 3000 Gauss. You have to be using just normal, your routine MRI scanning sequences for these patients, nothing exotic. The SAR has to be 2 to 4 over 15 minutes of scanning. And each manufacturer will specify their conditions under which you can scan a patient even right after you put the filter in. So these are known as MR conditional filters. They're usually the night and off filters. So there's some other unique alloys that are MR conditional as well. It's the stainless steel or the ferrous filters where there's more of a concern. And again, that would be the stainless steel green filter or the bird's nest filter. There's a possible risk of movement, migration, heating, current induction, and it's recommended that MR scanning be delayed for at least 6 weeks after you place one of these ferrous filters. But again, most filters that we're placing today are MR conditional, meaning that you can scan a patient at any point after they're placed if they fulfill these manufacturer-specified conditions. So, okay, thank you very much.